exist for me. So thank you very much for having me. So it's great to see that you've already been discussing a bit about cognition. So it is important to study decision-making in people living with ALS because, as you all know by now, this is a spectrum disease that ranges from 50% of the cases that only present motor symptoms to around 15% of the cases that end up developing ALS frontotemporal dementia. There's also, in this spectrum, around 35% of the cases that develop some milder changes in their cognition and or behavior. However, it is currently unknown whether these changes can have an impact on the person's decision-making and mental capacity. In relation to the changes in behavior that some people with ALS may experience, it's including socially inappropriate behavior such as disinhibition, apathy, which is a lack of motivation, loss of sympathy, empathy, and people perhaps start becoming a bit more self-centered or just showing a disregard for other people's need or distress, and also some changes in eating behaviors such as binge eating and over-drinking or excessive craving of sweet food. In terms of the changes in cognition, some people might develop language dysfunction, which can include problems with naming or spelling. There might also be some social cognition impairment, which is a difficulty to understand how other people think or how other people feel, and some executive dysfunction, which are higher order functions of organization, planning, attention, and decision-making. So people with ALS need to make important decisions throughout the course of the disease that can have a great impact on their quality of life. We conducted a focus group at the University of Edinburgh, and we found out that the type of decisions that they had to make were, from the very beginning, for example, who should I tell about the diagnosis? Should I stop working, go on holidays? Where should I live? Do I need to make any adaptations to my house? Should I bank my birth? Should I get a wheelchair? Should I join a clinical trial? There are also, I'm too short, so I'm just trying to look at the, look at the screen here. Also, particular decisions about treatments such as ventilation or feeding tube, and finally decisions about end-of-life care. Mental capacity is a legal term, and it's the ability to decide, to make a specific decision at a specific time in a specific situation. So we cannot say that someone has mental capacity or that someone doesn't have mental capacity, full stop. This is something that needs to be considered in a particular context. So in the UK, we have the Mental Capacity Act, and it says that you should assume that someone has mental capacity unless it's proved otherwise. So to say that someone has mental capacity, you should consider the following 4 components. First of all, you should consider that they're able to understand and retain the information you provide, that they're able to use and weigh up this information, which is basically identifying pros and cons. This is also known as reasoning. And finally, that they're able to communicate their decision. So we know from research conducted in people with other neurological conditions that the cognitive and behavioral impairments could affect how well someone perform on a mental capacity assessment. And for example, language dysfunction could affect how people understand and communicate information that is relevant to their decision. Executive dysfunction could affect attention and also could affect how people are able to retain the information we provide to them, but also could affect how people consider the consequences of their actions. Deficits in social cognition can affect how people consider the consequences of their actions on other people, such as their loved ones. And finally, apathy could affect the whole, all the components of the mental capacity assessment. If the person doesn't have the motivation to undertake the assessment, or if they are unable to generate new ideas or responses to our questions. So now I would like to share with you some of the results of a study that I will be presenting tomorrow at the MND symposium. So COG15 is the number of the poster. It looks like the name of a gene or something, but no, that's the name of the poster. And this is a study funded by MND Scotland on mental capacity to make treatment decisions in MND. So we look at exploring if mental capacity to consent to medical treatments, in particular gastrostomy or feeding tube, was affected in people with MND. We also wanted to assess if their performance in mental capacity assessment could improve with appropriate support. And finally, we wanted to investigate the relationship between mental capacity and cognitive impairment. To achieve this, I interviewed 21 people with MND and 14 controls. These controls were matched in age, gender, and education. They all completed an adapted version of the MCAT-T, which is a tool to assess mental capacity to consent to a gastrostomy. And we also asked them to complete an ECAS to measure their cognition and their behavior. So from these 21 participants with MND, 16 of them also completed a repeated version of the assessment of their mental capacity, but the second time we used some support strategies. So the information that they received, it was exactly the same content, but this time it was presented with some images. We also made some changes to the way we were asking the questions so they could be more specific rather than general and open questions. And we also asked them to complete a comparison table so they could consider the consequences of each action. But I will discuss the support a little later. So in terms of preliminary findings, so this figure shows the main differences in mental capacity components between people with MND and controls. So what we found is that the MND group performed significantly worse than the control group in the components of understanding and retention, also in the component of reasoning, which is the weighing up of information that I mentioned before, and also in the total mental capacity score. So from the 21 participants, 3 had impairment in understanding and retention, 6 presented impairment in reasoning, and 3 in both. So that's a total of 12 participants that had difficulties with the mental capacity assessment and that they should be probably classified as impaired mental capacity. In terms of cognition, 6 participants out of 21 were classified as ALS with cognitive impairment. 5 out of 15 had behavioral impairment, and 3 out of 15 had both cognitive and behavioral impairment. So for reporting the behaviors, we asked a study partner, which was in most cases a relative or a friend, to provide information about these behaviors, but not all the participants had a study partner. So that's why it says 15 rather than 21. So now, does cognitive impairment predict mental capacity? Well, because of the small sample size, we couldn't perform a regression analysis. But what we found is that from the 12 participants that had mental capacity impairment, 6 of them also had cognitive impairment. There are also other factors that could affect how people perform in the mental capacity assessment. For example, behavioral impairment, which is something that we didn't consider in this particular study. And there was also something that we didn't measure quantitatively, but it was coming up quite frequently during the interviews that I conducted with them. And that was the emotional component of having to make these treatment decisions. So that's something that perhaps could also affect how people perform in the mental capacity assessment. Now, looking at the main differences in mental capacity without and with support in people with MND. So this is intra-subject. It's the same people that perform the assessment twice. We found that the use of support strategies during the mental capacity assessment significantly increased the performance of people with MND in the task, and there was a particular significant improvement in the score of understanding and retention and reasoning. So in summary, these preliminary findings suggest that some people with MND have problems in decision-making and may lack the capacity to make specific treatment decisions. As I mentioned, mental capacity, it is very specific to the decision and to the time that we are conducting the assessment. When compared to controls, people with MND perform significantly worse in cognitive and mental capacity assessments. there were also 50% of the participants who failed the mental capacity assessment that were classified as ALS with cognitive impairment as determined by the ECAS. As I mentioned, there might be other reasons explaining why people perform like that in this assessment, and we hypothesize that this could be due to the apathy, for example, or behavioral impairment, and also due to the emotional impact that it has having to make these treatment decisions. Finally, appropriate support strategies may enhance overall mental capacity in people with MND, in particular the ability to understand, retain, and weigh up information. So I would like to finish this presentation by giving all the healthcare professionals here today, and also those that are seeing the streaming, just to give you some recommendations for supporting people living with ALS when making decisions. These are all based, like in this treatment decisions, but I think that some of them could also be applied to other contexts. In terms of supporting the understanding and retention of information, we recommend to ensure that the information is written clearly and in lay terms. This seems quite obvious, but sometimes for specialists, they are so used to certain type of information, they think that it's clear, but it's not. Also, it's recommended to present it in short and bulleted or number paragraphs, and to include images of how, for example, if it's a treatment, how does it look like in someone that has the treatment, or cartoons, something that could facilitate the understanding of abstract or specific information. It's also recommended to include information about alternative options as the consequences of making no decision when possible. It's also recommended to be as honest as possible with the risks of certain treatments, or like the negative consequences of choosing determined treatments, for example. And also provide the information in advance so the person can read it before the appointment and as many times as needed, because this will give the person more time to understand the information, to digest it, and also to think about questions that they might want to ask in the next appointment. And use short and specific questions and or prompts if the person struggles to answer broad questions. However, it's important to be careful with the type of prompts that we give, because you don't want to influence the person responses. And also, it's something very important to leave aside our own personal or moral judgments about certain things, because at the end of the day, we are just there trying to support the person making an autonomous and a decision, and an informed decision that should be based on their own values rather than ours. Also, for supporting the weighing up of information, this is something that we did, and it was proved to be very beneficial, to let the person making the decision complete a pros and cons table to help them compare the available options and test their ability to use information provided. So, for example, in our study, we asked them to complete a table where they were comparing having the gastrostomy tube and not having the treatment. And we use these specific categories, for example, health benefits and advantages, health risks or disadvantages or complications, positive and negative impact of their decision on their everyday activities or everyday life, and also the positive and negative impact of their decision on their relatives or loved ones. So in our study, we would start for their preferred option. Let's say that if they were favoring having the treatment, we will begin for that option, go over all these categories, and then move on to the next one. Finally, for supporting the communication of the decision, it's important to take into account the communication needs of the individual, particularly those with bulbar onset ALS, and consider involving the carer or a relative or any other professional who can assist you, as long as they can be objective and, again, not influence the person making the decision. It's also recommended to give time to discuss the information relevant to the decision they need to make, and this might require discussing the decision in more than one opportunity and appointment. And finally, be patient. This is very important. Be empathetic and consider the emotional implications for the person making that decision. So in our study, we found that deciding if they wanted to have the treatment or not. It was seen as some people as a decision about wanting to prolong life or not, and under which conditions. For other people, accepting having the gastrostomy was like a realization that they were in the late stages of the disease or near the end of life. So for this reason, people try to delay the decision for as long as possible. So yeah, in general, just consider that as well. Thank you very much. So as I mentioned, I will be presenting my poster tomorrow if you want to discuss more of that. And that's my lovely group with Professor Sharon Abrahams. Thank you to all the participants and to MND Scotland for funding the study. Thank you.
Thank you, Milena, for such an important talk. I think people living with MND have so many choices and decisions to make throughout their journey. You've given some very practical ideas and thoughts for that. You have one question? You have no question? There is a question here in the room, but while the microphone's going, I was thinking, is there times when you've had to think about person's best interest and actually all of your strategies might not have kind of helped completely and you've had to make decisions in somebody's best interest?
So in most of the participants we had, they performed worse in mental capacity assessment, and they also had impairments in certain components of the mental capacity assessment, but they were able to answer all the questions. Yeah. So there was no need to use like a welfare attorney or how you call it in England. I'm thinking about how you call it in Scotland, or a consultee. Yeah. So they were able to, but basically this study is to show that with certain support, people might be able to make these decisions autonomously, and perhaps there's no need to include someone else to consent on their behalf. But again, there might be some people with a more severe FTD that in those cases, perhaps, yeah, it's needed to include someone else.
Thank you. I think that's very valuable. You have one question?
Thank you so much. Do you have recommendation and screening tools? I mean, you can do long testing, but is anything that you can give in 5 minutes and say, okay, you have to have further testing and you're okay? Can you have screening tools? And the second is, if this is progressive, do you have tools that you can repeat at a later time to see if the cognition of the capacity has changed over time? Let's say 6 months later, a year later, can you repeat the same test? Do you have anything to measure progression in terms of cognition?
That's a really good question. In terms of cognition, yes, there are many tools, like the ECAS, for example. But in terms of mental capacity, I think it's important to mention that a lot of people, they think that mental capacity and cognition are synonyms, and if they do well at a cognitive assessment, then they don't have mental capacity problems. And what this study is showing is that people that have mental capacity impairment might be for other reasons, not only cognitive impairment. So ideally, I know that depending on which country are you in, but ideally psychologists, clinical psychologists, neuropsychologists should, if you have some concerns, could undertake a mental capacity assessment. It's more like a clinical interview. But it's basically to be able to test that the person is able to understand, retain, and weigh up this information and communicate their decision. And that's something that you can repeat more than once. But I think it's about finding the balance, because as I mentioned, at least in the UK, you should assume that the person has mental capacity unless it's proved otherwise. So it's tricky, but that's why we think that perhaps with this kind of support strategies that any kind of healthcare professional can use, perhaps that could help people with those decisions.
Good. Thank you very much. Thank you.
Thank you.